Hello and welcome to tonight's webinar, Prostate Cancer in Your Family Tree, Implications for Cancer Risk and Genetic Testing. I am Sienna Breen, Patient Support Programs Coordinator at Zero, the End of Prostate Cancer, and I will be your moderator this evening. We are joined tonight by two guest presenters, Dr. Vita Giri and Colette Hyatt, both from Sidney Kimmel Cancer Center at Thomas Jefferson University. This program is hosted by Zero with support from Myriad Genetics. Just as a general overview of how this is going to work, we are expecting this program to last about an hour. In a moment, I'll give an overview of Zero and introduce our speakers, and then I will hand it over to Dr. Giri for her presentation. After her presentation and time allowing, we will have a question and answer session. At any time during the presentation, if you do have a question, please type it in the chat box, and we will get to as many as we can during the Q&A session. We are recording this webinar and we'll be posting it on Zero's website, which is zerocancer.org, after the program. Now, just a little bit about Zero for those of you who are not familiar with our organization. Zero, the End of Prostate Cancer is the leading national nonprofit with the mission to end prostate cancer. Zero advances research, improves the lives of men and families, and inspires action. Our mission is to create Generation Zero, the first generation of men free from prostate cancer, and we are doing this through our National Run Walk series, education and patient support programs, and grassroots advocacy. We have two guest presenters this evening. The first guest presenter is Dr. Vita Giri, who is an associate professor of medical oncology and cancer biology at Sidney Kimmel Cancer Center at Thomas Jefferson University. She is a medical oncologist with advanced training in cancer risk and assessment, clinical cancer genetics, and molecular genetics, and has a clinical and research interest in inherited prostate cancer risk assessment. She is the Director of Cancer Risk Assessment and Clinical Cancer Genetics at SKCC, which has a translational focus on state-of-the-art patient care, along with innovative research and patient-centered initiatives. Our second guest presenter is Colette Hyatt, who has been a practicing genetic counselor specializing in hereditary cancer risk since 2013. She received her master's degree in genetic counseling from Arcadia University in Glenside, Pennsylvania in 2013. She also has a background in bioethics and received a master's degree in bioethics from Union Graduate College in 2011. Colette has been with the Jefferson Cancer Risk Assessment and Clinical Cancer Genetics program in Philadelphia, Pennsylvania since June 2015. All right, and now I'm going to turn it over to Dr. Giri for her presentation.
Well, thank you very much, and it's certainly a pleasure to be here today, and I'm honored to give this presentation through Zero Cancer, focused on prostate cancer and your family tree, and how family history information can be used for cancer risk assessment and implications for cancer risk and genetic testing. Just in terms of disclosures, I'm not speaking on behalf of any company, commercial entity, or sponsor of the event. And what I'm going to cover today is a brief overview of prostate cancer, knowing that many of those on the line or on the webinar have significant familiarity with prostate cancer, but some others may not. So just to quickly cover that, and then launch into the importance of family history and the details involved in family history intake, how that factors into the cancer risk evaluation process, provide some more information about genetic counseling and the genetic testing process and how that works hand in hand with information about prostate cancer and the connection of prostate cancer with a family history of prostate cancer, but also with other cancers in the family, as we are learning more and more about. And then to end, discussing current genetic testing approaches for prostate cancer and how the family history and genetic information is starting to inform prostate cancer screening, but also treatment for prostate cancer. So very quickly, as most of us know, prostate cancer remains the most common non-cutaneous or non-skin cancer that is diagnosed in men in the United States, and it is estimated that in 2017, that prostate cancer will be the third leading cause of cancer-related death in U.S. males. Research has shown that up to approximately 10% of prostate cancer may actually be due to a very strong inherited predisposition or genetic mutation leading to the development of prostate cancer. And family history is one of the risk factors that has been an established risk factor for prostate cancer, particularly the family history of prostate cancer. But there is more and more information emerging on the connection of other cancers and families and the link to prostate cancer as well that I'll get into later on in the presentation. So just really quickly, in terms of what is the prostate gland, as most of us know, this is a part of the male reproductive system that actually sits below the bladder and in front of the rectum, so it is deeply embedded in the pelvis, and this is one of the reasons why thinking about how to do a prostate biopsy is a transrectal biopsy, just given the anatomy of where the prostate is located. The role of the prostate is to produce elements that are part of semen. So the normal size of the prostate gland is about a walnut size, and it can increase in size with age or other prostate-related problems. When cancer develops in the prostate gland, it is staged according to a staging system, going all the way from stage 1 to stage 4, stage 1 being very localized prostate cancer in less than 1/2 of one lobe. Stage 2 still remains in one lobe of 2A, remains in one lobe of the prostate. 2B is when we see prostate cancer extending into the other lobe of the prostate gland. Stage 3 is more advanced prostate cancer, where it extends into the seminal vesicles. And stage 4 is actually much further extension of the prostate cancer into bone or even beyond afterwards, which would be metastatic disease. The other factor that's looked at in terms of prostate cancer aggressiveness is the Gleason score. And the Gleason score is basically looking at the pathology of prostate cancer. And it really looks at what do the cells look like under the microscope. Normal prostate cells look very much, well, you know, the normal cells are 1, but the more elevated we get in the Gleason score, the more the cells lose their architecture and look of normal cells. So as we go all the way from Gleason 1, but really more into Gleason 3, 4, and 5, we see that the cells become much more abnormal looking. They lose their glandular structure, and the pathologist looks at these cells under the microscope and looks at what is the primary pattern of the cells and gives that, takes that score and adds it to what is the secondary pattern of the cells, the second most common pattern, and from there derives a Gleason score for prostate cancer. Typically, Gleason score 8, 9, and 10 is considered to be the most aggressive types of cells of prostate cancer. Even within Gleason 7, there can be a difference between a Gleason 4+3 prostate cancer or a Gleason 3+4. All of this becomes important in terms of thinking of why we're talking about stage and Gleason score later on when we talk about implications for referral of patients for genetic evaluation or genetic testing. So this just shows the leading sites of cancer cases estimated for 2017. And what we see for males is that prostate cancer estimated cases in 2017 will be over 161,000 new cases of prostate cancer, and over 26,000 men will die from prostate cancer, is estimated in 2017. And when we look at these estimates, of course, one of the questions that comes to mind is who will be those individuals who might develop prostate cancer and ultimately die from prostate cancer or have the most aggressive disease. And one of the factors that is really important in thinking about risk for prostate cancer, and of course, which is the topic of the presentation, is family cancer history. And what is the importance of family cancer history in gauging risk for prostate cancer? So when we think about the importance of family cancer history, really in any cancer risk, family history is used in the estimation of cancer risk. And when we think about the spectrum of risk for cancers, it can be on the spectrum from what's called sporadic cancer all the way to familial risk and then hereditary cancer syndrome. So sporadic occurrence of cancer is where cancers in a family are likely occurring due to just factors within the individual or by chance, potentially exposures. Familial cancer is when we see more cancers than expected by just chance in a family. And here there can be a mixture of environmental factors, and genetic factors that are leading to a modest increase in risk for cancers occurring. But when we go all the way to hereditary cancer syndromes, we're really looking at a significantly greater pattern of prostate cancer or other cancers occurring in that family, particularly younger ages of cancers occurring, or specific types of cancers that are occurring in the family. So the family cancer history fits a particular pattern that is suspicious for hereditary cancer syndrome. And in this case is where we're looking for a genetic mutation that could be a known reason for inherited risk for cancer. Here, we see a substantially increased risk for cancer development. And so what you can see is going from sporadic to familial to hereditary, there can be population level risk all the way to increased, somewhat modestly increased risk in the familial category, and then a significantly increased risk in the hereditary category. And this can impact how we screen for cancers, where there's routine screening usually done for population level risk, somewhat more heightened screening in the familial category of risk, where there might be maybe screening beginning at a little bit of a younger age than what we might think of for the routine screening strategies, and then heightened screening for those that are in the really substantially higher risk who have a hereditary cancer syndrome. This can be screening that is done at a much younger age. For other cancers, not in prostate cancer, adding on additional screening tests could be done in this case. Chemoprevention or preventive surgery, again, not for prostate cancer, but for other cancers. So these are the types of risk estimation that we're actually interested in looking at, and family history becomes a very critical part of estimating risk and thinking about how to identify a hereditary cancer syndrome. So how do you actually evaluate cancer risk? This is just a very simplified model that looks at what we do when we see a patient in the clinic who is concerned about risk for cancers. And so what you see here is there are factors such as family history, personal cancer features. Some of the things would be what was the age of diagnosis of the cancer for the patient or in their relatives. Specific pathology of cancers can be important in the personal cancer features. And then, of course, we have to consider other risk factors such as smoking, alcohol intake, or other exposures that could have led to cancer occurrence. All of this information is used to estimate risk, but also at the same time determine suspicion for the highest level of risk for hereditary cancer syndrome, in which case those patients are referred for genetic counseling to go over the elements of genetic counseling, the discussion of the benefits, risks, limitations of genetic testing, and to reach an informed decision on genetic testing. Once the genetic testing is pursued and if a genetic mutation is identified, that information, along with information about familial cancer risk, is really used to inform several things for both individuals that are affected with cancer as well as unaffected with cancer. So those individuals that have already had a cancer could be at risk for additional cancers, and the specific gene mutation, or really the gene itself, could help to identify those cancer risks. More and more cancer genetic information is informing treatment of cancers. And of course, then we can proceed and do genetic testing in relatives to assess their cancer risk. For unaffected individuals, so those that don't have a cancer, the information is used to inform screening and prevention approaches, and also to test relatives for the familial mutation. Even if there is no genetic mutation, though, family cancer risk, just looking at the number of relatives affected, their ages of diagnosis, and their types of cancers becomes really important, even in allowing us to make recommendations for affected individuals or unaffected individuals. So as you can see, family history right off the bat is a very integral part of this entire cancer risk evaluation process. I wanted to get into a little more detail, though, about this part of the process that family history leads into, because it's going to be important when we talk about this regarding prostate cancer. And that really is this process of genetic counseling and talking about the role of genetic testing and approaches for genetic testing, just very briefly. So the process of cancer genetic testing really starts and is the leaders in this field are the genetic counselors. And genetic counselors are healthcare professionals that are trained in clinical genetics in the assessment of personal risk for cancer and options for managing that risk. And they are the professionals who actually collect information on family cancer history, the patient's personal health history, bring in pathology reports, perhaps genetic testing that was already done in the family, and pull all of that together to try to estimate or determine the suspicion for a hereditary cancer syndrome. They go forward then and discuss how cancers can be inherited, the benefits, risks, and limitations of doing available genetic testing and giving the options to patients. And then what are the implications of certain genetic test results for the patient and their family, such as what potential cancer risks could be uncovered, what does this mean in terms of future generations and children, and also insurance laws and genetic information. They also, really want to factor in patient choices and personal values and beliefs and goals of the patients to reach the right decision for the patient and really the best decision for the patient. And they also help to coordinate further genetic counseling and testing in the family for other family members as needed. So once we determine that, a patient should be seen by genetic counseling, the question becomes, what would be the information that is needed? And one of the key pieces of information that genetic counselors collect is family history, of course. And when we're thinking of what is the information that we need in family history, we're really interested in looking at least 3 generations of information, if that is available. It's recognized that family history information, it can be challenged to get that information. It may just not be available. It may not have been communicated, or it could have been lost through the generations. But ideally, we'd like cancer information in 3 generations. Very important to look at both sides of the family, maternal and paternal relatives. We do see patients that have prostate cancer tending to think about their paternal side of the family. We see women concerned about breast cancer tending to think of their mother's side of the family, but it's really important to consider both sides of the family. Information is important to gather on unaffected relatives in terms of whether they passed away, what did they pass away from, if they did they undergo screening, did they have any preventive surgeries, or could they have had any other manifestations or clinical manifestations of any hereditary cancer syndromes. Information on affected relatives, so family members that have had cancer, that's important to have is their age at diagnosis, treatment that they had, stage, and also, laterality of their cancer. Meaning, was their cancer, such as for breast cancer, did they have breast cancer in both breasts, such as bilateral breast cancer, or just one side? Ancestry is also important information to have because it can actually guide us to some of the genetic testing that could be in what's called founder populations or originating in certain parts of the world. So this is really important information, but we do recognize that this may not always be available in family history, but this is really critical to start thinking about what are the genes to test when we're concerned about an inherited risk for cancer. So really quickly, what is a gene? And I know most people perhaps on this webinar know this information already, but just to orient everybody, as you know, the DNA is packaged in our cells in chromosomes, and within our DNA are the coding regions, which are the genes. They are the drivers or operators of our cells, and they encode proteins which actually perform the functions of our cells. Related to cancer, this can be telling our cells when to grow, telling our cells when to die, and sending out signals for those things and performing those functions. When there is a mistake or a mutation in a gene, the coding region is basically incorrect. And so therefore, the protein that is encoded may not function well, and this can lead to uncontrolled growth of cells, or cells are being told that they should not die. So we have an overgrowth of cells, and basically we have the cancerous process occurring through this particular mutation to abnormal protein function cascade. And so when we're thinking of genetic testing, we're actually looking at what happened in the gene and in the coding region to cause a mutation to occur. What is the mutation, and is that being passed along through the generations? When we're thinking about this in terms of cancer development, we have to remember that we have two copies of our genes, one copy from our mother, one copy from our father. And most of the time, if cancers are occurring in that sporadic fashion, like in the general population risk, there may be some period of time where we might acquire one genetic mutation. And then more time might go by where there is no cancer occurring because we still have one normal copy of a gene. But as time goes by, both copies of the gene may end up being knocked out or acquiring mutations. And because both genes are not functioning, then we can have the development of cancer. However, in a hereditary cancer syndrome, what's occurring is that one copy of a gene is already inherited with a mutation. And therefore, there's a shorter period of time until cancer occurs because we've already inherited one mutated copy of the gene, and then the second copy can become mutated over time. So therefore, cancers can occur at younger ages and more frequent rates of cancer in hereditary cancer syndromes. So basically, what is genetic testing then? What are we actually doing when we are testing for those genetic mutations or genetic mistakes? And here I want to clarify some of the different genetic testing or genomic testing approaches because patients and certainly even providers can have some confusion about these different approaches, and it becomes really important to educate about this. So that's why I have genetic testing in quotes because there's different approaches. So what we're talking about today is on this side of the spectrum where we're looking at inherited genetic mutations and inherited cancer testing. So once again, these are mutations that are inherited, and they substantially raise the lifetime risk of cancer development, as I just previously mentioned on the other slides. Here, we're testing individuals for these inherited mutations. Typically, the genetic testing is performed on a blood sample or a saliva sample these days, screening and reading specific cancer risk genes for mutations. And basically, that can be done now in technology where we can look at one or two genes or multiple genes at the same time in these larger gene panels, trying to look at genetic mistakes or mutations. The purpose of doing this type of genetic testing is, again, to inform cancer screening and prevention. It can help us to think about genetic testing in blood relatives and also inform testing in selected treatment in selected cancers. Another type of genetic or genomic testing that is occurring is actually tumor-based testing. And in this type of technology, we even have different types of approaches occurring. So one of the type of approaches is genomic tests. And in prostate cancer in particular, there are several genomic tests that are available, and they basically inform of how to manage prostate cancer. So for example, Decipher, Polaris, Oncotype, all of these tests are giving some information about how prostate cancer is going to behave and in order to help manage the prostate cancer based on this test information. Right now, these genomic tests do not provide any information on inherited cancer risk. So these are really used for prostate cancer management. But a second type of technology that has emerged over the recent years are tumor sequencing. And in this case, what's happening is that the tumors are actually being sequenced for hundreds of genes, looking at mutations in the cancer to help inform targeted treatment usually for advanced cancers. And it is in this setting that actually there's been recent papers that said through this tumor sequencing, about 5 to 10% of patients could have inherited mutations. And so this tumor sequencing area is actually informing also this inherited side of cancer genetic testing. So it's important to kind of keep those in mind when we're seeing patients and what type of test they had done, because a lot of times patients will say, "Oh, I had genetic testing," and they actually had one of these genomic tests as opposed to, really inherited cancer testing. So we're going to focus on the side of, again, the inherited cancer testing, looking at genetic mutations that substantially raise the lifetime risk of cancer. So going back to this risk evaluation model, again, one of the key features thinking about the risk for cancers in families is, of course, family history. So what is the risk for prostate cancer for a man who has a family history of prostate cancer? So there have been risk estimates published that look at familial prostate cancer risk. And what we can see here is that the risk can vary based upon who in the family is affected with prostate cancer and their age at diagnosis. So having a brother with prostate cancer can lead to a threefold increase in risk for prostate cancer in a male, and having a father with prostate cancer can lead to a twofold. So what's interesting is that actually having a brother with prostate cancer confers a greater risk than having a father with prostate cancer, though having the father with prostate cancer still, has over a twofold risk for prostate cancer development. Really, having any affected first-degree relative diagnosed with prostate cancer can at least double the risk for prostate cancer. And having prostate cancer diagnosed at young ages can also raise the risk of prostate cancer development for a male. It's also important to think about second-degree relatives, and those would be, for example, uncles with prostate cancer on one side of the family, so father's brothers or mother's brothers, where also there can be an increased risk for prostate cancer 2.5-fold. And really having 2 or more first-degree relatives, so brothers, father with prostate cancer, really substantially raises the risk, so over 4-fold increase in risk. If we look at even greater patterns of prostate cancer in families, then we become concerned about hereditary prostate cancer. So the prior estimates were looking at familial risk based upon family history of prostate cancer. But hereditary prostate cancer is actually one of those hereditary cancer syndromes. So what we see here are features of hereditary prostate cancer. And these are pedigrees. So just to orient everybody, the squares are men and the circles are women. And when a square is filled in, that person has had a cancer. In this case, it would be prostate cancer. And what we see here is where the arrow is pointing, the male has had prostate cancer, and then he has 2 sons that have also had prostate cancer. So this particular pattern, where there's 3 or more affected men in a nuclear family, so father and 2 sons, is one of the features of hereditary prostate cancer. Another feature is affected men in 3 vertical generations. So what you see here is, for example, the grandfather, the father, and the son, all having had prostate cancer. And here we suspect that maybe there was a genetic mutation that could have been passed along over the generations. Another feature of hereditary prostate cancer is 2 men in a family diagnosed at young ages. Typically, the sort of strict criteria were less than or equal to 55. And this would be 2 brothers that have had prostate cancer diagnosed at less than or equal to 55. And one of the first hereditary prostate cancer genes identified has been what's called HOXB13. And this has been identified in this particular scenario of hereditary prostate cancer. A genetic mutation in HOXB13 has been looked at for risk for prostate cancer and also for early onset prostate cancer, are really the 2 risks that have been identified and validated from HOXB13 mutation, and particularly one mutation that has been tested extensively. So the risk for prostate cancer can range from almost 3-fold to over an 8-fold risk for prostate cancer with a HOXB13 mutation. But really importantly, young age of diagnosis has been associated with HOXB13 mutations. So what about the connection of prostate cancer with other cancers in a family? And there is more and more information coming out about the connection of prostate cancer with other cancers in families. So one of those cancers is breast cancer. So one large study from the Women's Health Initiative reported that a family history of prostate cancer was associated with a 14% increase in risk of breast cancer in a family. And when there was a family history of both prostate and breast cancer, that was associated with a really increase in risk for breast cancer risk in that family of 78% increase in breast cancer risk. So while most of the studies are actually looking at breast cancer and the connection to prostate cancer, there have been other connections of prostate cancer with other cancers in families such as ovarian cancer and pancreatic cancer. depending on the gene. And there is also emerging data of the connection of prostate cancer with colorectal cancer, endometrial cancer, upper urinary tract cancer, and small bowel cancers. And these connections are coming out of specific hereditary cancer syndromes. A firm connection really is with hereditary breast and ovarian cancer syndrome, where we see excess of breast cancer, ovarian cancer, and then pancreatic and prostate cancer in those families. And some of the more preliminary data is in Lynch syndrome, which is hereditary non-polyposis colorectal cancer syndrome. Classically was a colon cancer risk with Lynch syndrome that was hereditary. But other cancers have been implicated in Lynch syndrome, including endometrial cancer, upper urinary tract cancer, and small bowel cancer. And there have been sporadic reports of the association of prostate cancer in Lynch syndrome as well. So in terms of looking at hereditary breast and ovarian cancer, those families have, again, an excess of breast and ovarian cancer. But the cancer risks that are after breast and ovarian cancer really are pancreatic cancer, prostate cancer, and melanoma. Here we see these cancers occurring at younger age at diagnosis. These cancers occurring in generational occurrence of these cancers, multiple cancers in the same individual, such as a woman who develops breast cancer and then develops ovarian cancer, or a man who has prostate cancer and could develop pancreatic cancer. Male breast cancer is a part of this particular syndrome as well. So while this is a rare occurrence, the risk is increased with hereditary breast and ovarian cancer, as well as Ashkenazi Jewish ancestry and cancer history becomes important as a feature of hereditary breast and ovarian cancer because of specific mutations in the genes linked with hereditary breast and ovarian cancer. And of course, those genes, as we all know, or most of us would know, are BRCA1 and BRCA2. So looking at the cancers that are linked with hereditary breast and ovarian cancer, of course, we can see a substantially increased risk of breast cancer with BRCA1 or BRCA2 mutations compared to the general population. There can also be risk of secondary breast cancer or a second development of a breast cancer that is substantially increased with BRCA1 or BRCA2 mutations. As you can see, there is a significantly increased risk of ovarian cancer compared to the general population with these mutations, certainly male breast cancer and pancreatic cancer as well. When we look at what is the data in prostate cancer, we do see that BRCA1 and particularly BRCA2, these are the genes linked with hereditary breast and ovarian cancer, do confer a risk for prostate cancer as well as early onset prostate cancer. Really, though, the data is the most robust for BRCA2 mutations, where there can be over a threefold but up to an eightfold risk for prostate cancer development. And in small subsets of those individuals can also have early onset of prostate cancer. But what's really important to recognize is that BRCA2 mutations have been shown to predispose to more aggressive prostate cancers. So these are the prostate cancers that are diagnosed with metastatic disease or advanced stage disease. And those individuals also have been reported to have poorer outcomes after treatment. So really, BRCA2 has been holding up in terms of its predisposition to prostate cancer and the link to hereditary breast and ovarian cancer syndrome in that family. And then what is Lynch syndrome? So as I mentioned, that is a hereditary non-polyposis colorectal cancer syndrome. So here we can see colorectal cancers diagnosed in individuals at a young age. We can see other cancers linked with this syndrome. There are multiple cancers there that are shown below: endometrial, small bowel, ovarian cancer, renal pelvis cancer. We can see this in one or more first-degree relatives, which would be, your immediate relatives, parents, siblings. But also we can see them in more extended relatives as well when looking at the patterns of these cancers in these families. And again, what we can see is when we compare this cancers that are occurring in Lynch syndrome to the general population, we do see that colon cancer risk is substantially elevated with Lynch syndrome with a younger age at diagnosis. And we can see several other cancers that are also involved in Lynch syndrome. endometrial, stomach, ovarian. And so here we can see that the risk for these cancers occurring by the age of 70 are substantially higher when Lynch syndrome is diagnosed. And the genes that are accounting for Lynch syndrome are what are called the DNA mismatch repair genes. And there's a group of these genes that basically repair areas of DNA, and when they are mutated, they're not working properly to repair the DNA, leading to inherited genetic mutations. And so if we look at the data in prostate cancer for the Lynch syndrome genes, this is, again, sort of a preliminary data, not as robust as in BRCA2 or HOXB13, but there appears to be, from some of the studies, some increase in risk for prostate cancer when there is a suspicion for Lynch syndrome or when there's a DNA mismatch repair gene mutation, as well as one study that found a risk for early onset prostate cancer. But again, that data is somewhat preliminary and needs to be confirmed going forward. So as you can see, the suspicion for inherited cancer risk really is now, it's first of all very important to consider family history of prostate cancer, but it's going beyond that as well in terms of really thinking of additional cancers in families. So it's really important to look at the cancers that are occurring in first-degree relatives. Again, those would be parents, siblings, children, or second-degree relatives on maternal and paternal sides of the family. Important to get information on early onset prostate cancer, so age particularly less than or equal to 55. And as I mentioned, prostate cancer information and risk based upon family history of other cancers, such as breast and ovarian cancer, with emerging data for colorectal, endometrial, and the other cancers of Lynch syndrome. And I do need to mention here, even though it's not right now tied in with family history, but we are learning more and more about mutations that are inherited in men with metastatic prostate cancer. There have been a few recent studies, and particularly one large study in the New England Journal of Medicine very recently that found that there were substantial rates of mutations in DNA repair genes, and in particular in BRCA2, among men with metastatic prostate cancer, irrespective of family history. So this is becoming a very important sort of criterion to think about referring which men for genetic evaluation and genetic testing. So I just wanted to make that point that metastatic disease and prostate cancer is another scenario where we're uncovering more inherited mutations that can predispose to cancer risk. So at our institution, we have a genitourinary or GU cancer genetics clinic. And this was the first genetics clinic in the Philadelphia region that was focused on cancer risk evaluation and genetic testing for GU cancers with a focus in prostate cancer, where we linked it to the multidisciplinary evaluation of prostate cancer. And what that means is having a patient with prostate cancer being evaluated for their management by urology, by radiation oncology and medical oncology, and at the same time having the opportunity to be seen by us in genetic counseling and genetic testing to see if there was an inherited risk for their prostate cancer development. The clinic is conducted, like I said, in parallel with the multidisciplinary clinic, where men have the opportunity to undergo genetic evaluation and enroll in research studies. So it was through this clinic that we started to uncover some of these patterns of the connection of prostate cancer with these other hereditary cancer syndromes. So for example, here's a pedigree of a patient that we saw where the arrow is pointing here with prostate cancer diagnosed at 52. He had a Gleason 7 prostate cancer. His brother had prostate cancer at 59. Then we go up a generation and we see that his father had prostate cancer diagnosed at 60. Father's brother had prostate cancer, and the father's father also had prostate cancer. And so here we see this generational pattern of prostate cancer, but we also see two brothers having had prostate cancer. So this fits criteria for hereditary prostate cancer. This is an example of an individual that we saw that had prostate cancer diagnosed at 49, Gleason 8 prostate cancer. His sister had breast cancer diagnosed at 49. And then we go up to his father's generation, and this highlights the need to take family history of both sides of the family, because what we see is two aunts that had ovarian cancer on the father's side of the family. So this particular pattern fit features of hereditary breast and ovarian cancer, and our index case was our patient with prostate cancer. And then this particular pedigree highlights suspicion for Lynch syndrome, where a patient had prostate cancer diagnosed at 60. His brother died of colon cancer at a young age. Their mother had uterine cancer, and the mother's brother had colon cancer. So this particular, again, pattern fits with suspicion for Lynch syndrome, and this was uncovered by seeing the patient with prostate cancer. So this really is now an emerging field of genetic evaluation for prostate cancer. So once we've been seeing these patients and thinking about genetic testing after genetic counseling, we want to talk about, what are the different types of tests that are now available for genetic testing for prostate cancer based upon suspicion of family history and also the patient's own features of their prostate cancer. So as I mentioned before, we now have the ability to test multiple genes at the same time. And so several of the labs have actually put out multi-gene panels. Some of them are not necessarily specific to a particular type of cancer, but can be sort of related to different cancer risk development. But some of them are prostate cancer panels. And so what you can see here is that BRCA1 and BRCA2 are on these panels. HOXB13 has been on some of these panels. Some of the Lynch syndrome genes are on these panels, such as MLH1, MSH2, MSH6. But there are several other genes on these panels as well. And the question becomes, what do we tell patients about these multi-gene panels so that they can make an informed decision about genetic testing? And so we really do have to break it down in the genetic counseling setting to the benefits and considerations. So some of the benefits of these multi-gene panels is that, of course, we can test multiple genes at one time. So if a patient comes in and has one gene tested negative, in the past they'd have to come back and have another gene or set of genes, and it would lead to fatigue in the whole process. And now we can actually sort of address and look at multiple genes at the same time. We could uncover cancer risks that we wouldn't have otherwise suspected based upon the known information in a family or that the patient themselves may know. And of course, the information can be used to inform cancer screening and or treatment more and more for several types of cancers. But some of the considerations to think about are that really of these genes right now, the clear risk for prostate cancer has been just in a few of them, BRCA1, BRCA2, and HOXB13. It's unclear about the risk of prostate cancer and certainly what do you do with this information in terms of management with several of the other genes, though that should be evolving over time, but at the present time, that might be unclear information. We may otherwise, uncover other cancer risks, again, that also don't have clear management based upon this time and the current state. We see quite often that there might be mutations identified in the patient that don't match the patient's type of cancer or the family history that the patient reports. And so that can lead to concern and just a difficult situation in terms of what we tell patients about the risk of cancer based upon the genetic test results. We can also uncover what are called variants of uncertain significance, which is that there is a change in a gene which it's not clear at this time whether that's a mutation or just a normal change that could be there. That's just a silent change. And these are reported out to patients and can lead to some anxiety for patients about, am I going to get cancer? Is this a mutation? Those variants of uncertain significance are followed by the genetic testing laboratories and get reclassified over time, many of them to benign, but some of them can get reclassified to pathogenic or actually a mutation. And so therefore it becomes an issue to follow those variants over time, but those are reported out to patients. So with these multi-gene panels, it really does become important to discuss these benefits and considerations prior to proceeding with genetic testing. So what are the current guidelines for genetic testing for prostate cancer? They're pretty limited at this point in time. The National Comprehensive Cancer Network, or the NCCN, basically specifies that if a man has prostate cancer that's a Gleason score greater than or equal to 7 at any age, or with greater than or equal to one close blood relative, and they define that as a first-degree relative, a second, or a third-degree relative, with ovarian cancer at any age or young breast cancer, or 2 relatives with breast, pancreas, or prostate cancer, Gleason greater than or equal to 7. So it's kind of like this permutation, kind of confusing puzzle, but when we break it down, it's basically the man with Gleason score greater than or equal to 7 with a family history of any ovarian cancer could meet criteria, young breast cancer, or 2 relatives with a breast, pancreas, or prostate cancer greater than or equal to 7. So these are very specific guidelines right now that are available for considering genetic testing for BRCA1 or BRCA2 for men with prostate cancer. And that information, again, it goes back to this one of our earlier slides, which is what is the importance of family history to meet testing criteria. We need to know that family history in terms of the history of breast cancer, ovarian cancer, pancreatic cancer, the Gleason score of the patient with prostate cancer, and factor all of that in terms of the consideration for genetic testing. So when we think about this, we're actually on this side of the spectrum thinking about a hereditary risk for cancer with a greatly increased risk of cancer development. And in this case, it can lead to considerations for heightened screening starting at a much younger age than is recommended for the general population. Some of those guidelines, and there's not actually sort of a routine consensus, and as we know in terms of the screening world for prostate cancer, there can be different guidelines from different professional organizations. But in terms of those that have looked at genetic mutations and screening, the National Comprehensive Cancer Network, NCCN, recommends that a male who carries a BRCA2 mutation should have a baseline PSA at 45 as opposed to 50. And for a man who has a BRCA1 mutation, to consider that same recommendation. So it's a little bit softer than for BRCA2 carriers. And that's really based upon more data in BRCA2 with risk for prostate cancer and aggressive prostate cancer as well. A separate panel in the NCCN, the Prostate Cancer Early Detection Panel, mentions to factor in family cancer history, family history of BRCA mutations, and race as well, considering that African American men have an increase in risk, and to start that screening discussion from anywhere from 45 to 47. So they give a range and give that leeway to the provider to gauge the risk and perhaps have that discussion at a younger age, but perhaps not. So it's a little bit looser in that sense. Another example of how family history is factored into guidelines is from the American Cancer Society, where you can see they state that start that discussion at age 50 for a man who is at average risk of prostate cancer and are expected to live at least 10 more years. Start that discussion at 45 if there's a higher risk of developing prostate cancer, and factoring in those risk factors would be I'm not sure if I just got this chat that there's no sound. I hope everybody can hear me. To factor in first-degree relatives with father, brother, or son with prostate cancer, particularly diagnosed at a younger age. And then to go even younger, age 40 for men that even have a higher risk, so more than one first-degree relative with prostate cancer, particularly diagnosed at a much earlier age. And again, that goes back to some of the higher risk estimates with familial prostate cancer. So this is where you can see American Cancer Society factors in family history in their screening recommendations or discussion of screening. And again, more and more genetic information is being informative in studies for sort of choice or options for targeted therapies. One of the group of genes is what's called the DNA repair genes, and mutation carriers may actually have better responses to targeted therapies, particularly in the advanced or metastatic setting. And there's more studies being reported in prostate cancer regarding DNA repair mutations and targeted therapies. So this is kind of how mutation status and family history are being factored into prostate cancer screening or management, but you can see they're very limited at this time and really focused around BRCA1 or BRCA2. This is one of the reasons that we are actually convening a consensus conference in Philadelphia that is focused on really comprehensively developing guidelines for the role of genetic testing for inherited prostate cancer risk. really expanding the evaluation to look at some of these other genes that have been emerging from studies to say, is there enough data to say if these genes inform testing, and all the way from risk assessment to treatment and screening models. So while we're sort of learning more about this genetic predisposition to prostate cancer, there really is a lack of guidance in how to incorporate that into comprehensive clinical genetic evaluation and then subsequent management, such as for prostate cancer screening, treatment, et cetera. And that's really sort of the overall goal of this Philadelphia Prostate Consensus Conference that's actually going to be occurring next week. And so we're going to be looking at developing referral criteria, so which men should be referred for cancer risk assessment or genetic counseling and genetic testing, how that genetic testing should be sort of approached, which genes should we think about testing for, and what does that mean for genetic mutation carriers as far as screening, treatment, and management, and also for people who don't have a mutation identified, what would we think about in terms of prostate cancer screening. So stay tuned for these consensus guidelines. We're actually going to be publishing them after the consensus conference and making them available to the certainly to the scientific community, but also to the patient education community as well. So to spread the word about what we sort of developed from our meeting. And of course, going back to the topic at hand here, family cancer history is going to be one key factor that we're going to consider over and over again in these guidelines development. Family history of prostate cancer, but also family history of other cancers when we're thinking about referral criteria, testing criteria, and then management and screening. So really, I think to wrap it up in summary, we know that prostate cancer is a common cancer. However, there is a substantial proportion that is due to familial or hereditary factors. And knowing the family cancer history is really critical in one step of estimating a man's risk for developing prostate cancer. That family history should include, of course, family history of prostate cancer, but really it should go beyond that now and include other cancers in men and women, male and female relatives in a family, so that we can think about perhaps other genetic testing that might be linked with other hereditary cancer syndromes. Family history is an important critical factor in informing genetic counseling and genetic testing, and these programs, cancer risk assessment or genetic evaluation programs, can really help to provide personalized assessment of cancer risk for men and women, and particularly in the setting of prostate cancer, to help men hear about this discussion, put it in light of their own health history, their cancer history if they have prostate cancer or other cancers, and in light with their family history as well, to help them make the best decision for themselves. And certainly we have a lot of support services available that I think Sienna will bring up here at the end, but you don't have to go through this process alone. There are programs available. We can help you to connect locally as well. And there's a lot of support available in these programs, but also online. So please feel free to reach out and get as much information as possible so you can make the best decision for yourself. So thank you very much for your time. I greatly appreciate the chance to speak today.
Thank you, Dr. Geary. So we've come to our question and answer session. We are getting close to an hour, so we will try to answer as many questions as we can. We've had quite a few, but if you have a question and you haven't posted it in the chat box yet, please do that, and we will get to as many as we can. Colette, just so you know, I have unmuted you. Let's see. So our first question that we have, and we do have a lot of questions. I think some of them have been answered in the course of the program. So I'm going to try and prioritize ones that I don't think have been answered and ones that are specifically related to the content of the program. So the first question that we have, my father was diagnosed with stage 4 prostate cancer at age 53 years old, went through quite a few treatments. He died at age 57. The question is, the doctors at Duke said when he was diagnosed that when his son turns 30, he would need to begin testing, with PSA not being a good marker for his father's disease. So what should the son be doing now that he is 30 for prevention and screening purposes?
Yeah, that's a really good question. We know that the PSA, first of all, is not a perfect test, and sometimes prostate cancer may be occurring and the PSA may not be rising. So those are all factors to consider. While the NCCN does say that, to consider earlier prostate cancer screening, and so does American Cancer Society, to think about having that discussion at 40, there would be rationale to perhaps even discuss with the son that maybe in his mid-30s to have a baseline PSA done, particularly because the father was diagnosed at a young age and even passed away at a young age, so that that baseline PSA can at least be on the record and then followed going forward, if it can be tracked for a change or the velocity of the PSA can be tracked better. Now, it sounds like, this could be an opportunity to think about genetic counseling and genetic testing as well to help get a better idea of the risk. And so there could be multiple factors, but I do think sort of evaluating the risk in the family and then just sort of reaching a decision that would be right for the son and the family would be the best way to go. Some of this is still an art at this point, but we hope that, again, with the consensus, we might be able to address this a little bit better.
Great, thank you. The next question that we have is, do you know if genetic testing or counseling are covered by Medicare?
I think I'll turn that over to Colette Hyatt, genetic counselor.
So that's also a good question. I think it depends on a little bit where you go for genetic counseling and also your personal history and your family history for genetic testing. So some centers don't charge for genetic counseling, so it wouldn't be a problem to get it through Medicare or any other insurance that way. But Medicare, if a center is charging, Medicare currently is not paying for genetic counseling. So I think it's probably best to reach out to some local people, and I can give you guys a link to find local genetic counselors and see, what they're doing for local centers. For covering of genetic testing itself, it does depend on your personal and your family history, but I do find that Medicare does cover genetic testing pretty well if you do meet certain criteria.
Thank you. The next question is, what is the risk for my twin brother getting prostate cancer since I had it?
And is it I guess I don't know if it's an identical twin or fraternal twin.
It did not specify.
If it's a fraternal twin, then it would be sort of the risks that we have in the literature for having a brother, with prostate cancer. You would think that, an identical twin, if there's a genetic mutation in the patient, would have inherited that same genetic mutation. So it's difficult to tell unless a mutation can be found. But regardless, there would be this elevated risk, and so it would probably be important to have the brother, plug in and engage with, either urology or cancer risk assessment to get a sense of that. And to think about, if genetic testing should be done in the patient.
Thank you. We are coming up on 9 o'clock. Dr. Gary, Colette, do you have a couple more minutes to answer a few more questions? Maybe 5 or 10 more minutes?
Sure.
Yeah, that sounds good.
Okay. For those of you who are attending who aren't able to stay, we are recording the webinar just as a reminder, and we'll post it on Zero's website after the fact. So it looks like the next question that we have is, my father passed away from prostate cancer at the age of 57 after being diagnosed at 55. I had prostate cancer at 50. I have two sons in their late 20s, and so would it be best for me to have the genetic test versus my sons who should get the genetic test?
So it's always best.
Go ahead.
Oh, sorry.
You can answer. No, go ahead.
So when it comes to genetic testing itself, it's always best to test someone who's had a cancer diagnosis, because almost in a way we're trying to evaluate what's causing the cancer in the family. So if we start some genetic testing in someone who's never had a cancer diagnosis, we just don't know at that point if we do genetic testing and nothing comes up. Maybe there's something in the family that wasn't inherited or wasn't passed on, or maybe we're missing something that we're not testing for. So best always to start in someone who's had that diagnosis.
Great. Thank you.
Yeah, and I support, yeah, I agree with Colette's response on that one.
Thank you. So the next question that we have is, I am 66 years old and was diagnosed and treated for prostate cancer at 66. I have since been diagnosed with 3 stage 0 melanomas, 2 cutaneous squamous cell carcinomas, and 1 basal cell cancer, 5 skin cancers in all. Are these at all related to my prostate cancer, and am I likely carrying a cancer mutation? Should I be genetically tested, and if so, what tests are available?
Yeah, this would be really important for this individual to, talk with genetic counseling, because it could be that they are related, genetically related, but also expanding the family history could be really informative. If there are other cancers in the siblings or in the maternal or paternal sides of the family, that could really help in terms of thinking of, what are the suspicious genes to test for, and then what does that mean, for the patient going forward and for relatives as well. So tough to exactly say which genes. There are certainly genes that are linked with melanoma and with prostate cancer. Some of those are also linked with other cancers. So, without specifying the exact genes, I think it would be really important to seek that opinion with genetic counseling.
Thank you. The next question that we have is, does identifying, if there isn't gene mutation, does identifying the specific gene mutation aid in the type of treatment that would be used to treat the cancer? Like, would it aid in determining what type of chemotherapy to use, for example?
So there's more information coming out in prostate cancer about the use of targeted therapies with specific gene mutations, particularly in metastatic prostate cancer. So these particular therapies are PARP inhibitors, and one in particular would be something like olaparib that was tested in the metastatic setting. And there was an improved response rate in those individuals who had metastatic, or what's called castrate-resistant metastatic prostate cancer. This same paradigm is being used in other cancers, such as in ovarian cancer now, where BRCA testing is being done to help along the sequence of treatments for ovarian cancer to determine the role for, again, PARP inhibition, targeted therapy for specific individuals with ovarian cancer and a genetic mutation. Sometimes it can also be helped in terms of guiding the use of chemotherapy. There is some information coming out about, should platinum-based chemotherapies be used in prostate cancer, metastatic prostate cancer in individuals who carry specific gene mutations versus don't carrying them. And that type of data is coming out. So yes, it can be informative, not for all cancers and at all stages of cancer, but in specific cancers and in certain scenarios. We are seeing that more and more. Also, immunotherapy is a big field that is growing out of this information on genetics, and so we're seeing immune therapy drugs being used in specific settings, such as with colon cancer, who have Lynch syndrome, and various scenarios. So it can help to guide the type of systemic therapy that we would recommend in different cancers.
Thank you. The next question that we have is, are genetic tests available to be done after a prostatectomy and radiation? Like, at what point in the treatment process for prostate cancer should a person seek genetic counseling or seek to have a genetic test done?
It could be at any point that we could see the patient. It can be after treatment. It could be before treatment. So it really, there isn't a sort of ideal scenario right now. As we go forward, and if genetic testing information is going to be important in actual discussions and decisions about how you manage prostate cancer, then of course it would be better to get that information before a treatment decision is made. But right now, at this point in time, certainly a man can come in for genetic counseling or genetic testing after they've had treatment as well. So.
Yeah, and I think it's also, it's important to really to come at a time that works best for yourself and for your family as well. When someone's newly diagnosed with a cancer, sometimes having an additional conversation about family history and additional cancer risk can be a lot. So really, it's best to work with what won't be overwhelming for yourself and for your family, for timing at least.
Thank you. The next question I have is, how much does genetic testing cost? So I guess if somebody was going outside of insurance, how much would it cost? And if you have that information, do you know how much usually people have to pay out of pocket for genetic testing?
If people go through insurance, it's normally covered pretty well. But there are some genetic testing is a lot, at least germline genetic testing is a lot cheaper than it used to be. There's some labs where we can do the testing for around $475, and another lab where it's around $250, which I know is still a lot of money. But if you talk to us even 2 years ago, we would have been talking about $4,000. So there is still the option to pay out of pocket if it works for someone and for their family as well.
Great, thank you. So I think we are out of time for this evening, so we will wrap up. For additional questions, I believe, Dr. Geary, that you talked to Drew about this, that we're going to potentially answer them in a follow-up email, since we have just a few remaining questions that haven't been answered. So just to wrap up, these are a few resources that are available to help people who understand and be proactive about their risk of prostate cancer and hereditary cancer in general. And just as a reminder to everyone who's still on, this is a recorded program and it will be available on Zero's website after the fact. So you don't have to rush to write all these down or anything like that. Okay, so this concludes our webinar. Thank you very much to our presenters, Dr. Vida Geary and Colette Hyatt, for being with us tonight and for sharing your knowledge with us. We would also like to thank our sponsor again, Myriad Genetics, for supporting this program. Thank you to everyone who joined us, and just so you know, when you close out of the program, you will be taken to a post-webinar survey. If you have a moment, please take the time to fill that out. We really do appreciate your feedback, and the feedback you give us helps us plan future webinars and programs. So thank you again, and have a good evening, everyone.
Thank you.
Thank you. Please stand by.